Hi, everybody, and welcome once again to the No CD Wednesday night webinar. And tonight, being the third Wednesday of the month, makes it our Diversity Matters series. We're really happy to have all of you here tonight. And just as a reminder, No CD is a free downloadable app that you can get on the iOS or Google Play Store. No CD also does teletherapy. So if you have an interest in getting therapy through the No CD providers, who are all specialty trained in OCD and exposure and response prevention, please feel free to reach out to us. And you know what I realized? This is funny. You'll laugh at me for this because I've been pointing this way where the link is, but it's reversed on my screen, so it's actually over there. But on my screen, it's like it's over there. So for weeks now, I've been doing this when it's actually been over there. So I think that's pretty darn funny as well. So tonight we're going to be talking about the links between autism and obsessive-compulsive disorder. And I have the pleasure of a good friend of mine who actually grew up in my neighborhood, even though we didn't know each other, because we were like West Side Story, I think is probably the best way you could describe us, right? But Maria, you want to introduce yourself and let everyone know a little bit about you and your background and what you've done, and then we're gonna go from there. So.
Sure. Thanks, Patrick. Thanks for having me on. Yes, we did grow up in the same neighborhood without knowing each other. To give you a little bit about myself, so I am a licensed clinical professional counselor. I have spent the last 20 years working with individuals who have neurodevelopmental disorders and counseling individuals with autism spectrum disorders and any comorbidities. I currently have a private practice in Oak Brook, Illinois and Arlington Heights, Illinois called MGB Services. I think Patrick has got some information if you'd like to.
I did. I put it in the chat already for everybody too, where they can get a hold of you. So yes.
Yes, and you're welcome to just call if you have any questions. I'm also a parent. I have an adult child with autism spectrum disorder and some comorbidities. So I've kind of lived a lot of this.
Right. And I just want to say, we were going to have one other therapist on tonight who also is a person who treats OCD and knows a lot about autism because she also has some children who have autism. But unfortunately, about an hour ago, an ambulance was at their house because her daughter fell, and we aren't sure yet if she broke her ankle or if it's a severe sprain. So she texted me from the ambulance saying, I'm not going to be able to be on tonight. And just in case anybody asks, because I know in some of our previous talks, we've had people with lived experience. And so what I want to do, and I'm in contact with a few people, we're going to do a lived experience panel coming up in the future of people with autism and OCD as well. So that's coming, but I wanted to be able to devote an entire hour to them and an entire hour to the professional side as well, because this is a topic that's been coming up more and more for us at NoCD on the app, and just more and more in the general population with the International OCD Foundation and things too, to ask about how OCD and autism interact. So Maria, and one question just came up in the chat already. What is autism? So I figured we'd start off first because, you know, this is your area, and I'm going to let you kind of take that. And I'd be interested in a little bit, if I could preface that, you know, the history of this. And we've had Asperger's, and then we don't have Asperger's, and autism spectrum and autism, you know what. So I'd be really interested to hear from you kind of what specifically are we talking about when we're talking about autism, neuro kind of area disorders, pervasive developmental disorders, those types of things. Yeah. Is disorders the right way to say that? You know, just all these kinds of things as we've got from DSM or not. And I think that this will be a great discussion, and I'm hoping we'll get some really nice questions also from the feed as well. So take it away for a little bit, please.
Yeah, great question. So you probably heard words like PDD, NOS, autistic, Asperger, Rain Man-like, a whole different set of different used throughout the years. Some of them don't exist anymore. The professionals out there in DSM world decided they were going to really examine and research how people were diagnosed, and that's how it became an autism spectrum disorder. So it is still a neurological disorder. None of that changed. It's a lifelong disability, Some of the things that have changed historically was there was an Asperger diagnosis. And there's been some discussion and different views on whether Asperger should have been taken away or not, because people who have that diagnosis of Asperger syndrome really identify with it, and it's not just a disorder, but it's part of their identity. So that was really hard with the group of individuals I worked with who had Asperger's, still referred to themselves as Asperger's. Why was that changed?
Aspies, I've heard too.
Aspies, yes.
Yeah,
there's blogs, everything. So why would they change that? So during the research, what they found is that there was really no difference in how Asperger's syndrome was diagnosed. So you could have gone to 5 different clinicians and you would have gotten 5 different diagnoses on whether it would have been autism disorder or Asperger disorder. So there was no clear delineation of how to diagnose someone as Asperger's. I wouldn't be surprised if that changes in the future again. So when DSM-5 came around, it ended up being just autism spectrum disorder. They removed you heard me say PDD-NOS, so it was pervasive development disorder. A lot of kids got that not otherwise specified, and that's historically was the umbrella for autism. And then Asperger's and Fragile X and all those other disorders fell within that umbrella. So now it's no longer PDD-NOS, rather there's autism spectrum disorder with different levels, and then there's specific identifiers. So that's where they would just see, is there an intellectual disability or not? Are there other comorbidities? How severe is the autism? We still know that the rates now are 1 in 54. In the US, we know that 1 in 6 kids has a developmental disability. And a lot of people with autism also fall under that.
Wow.
It's a
so one in 6. And could that be anything from like a learning disability to all the way through autism or something like that? Or okay.
All childhood developmental disabilities. So that's ADHD, intellectual impairment, dyslexia. They all fall under that category. With the new autism criteria, it's easier to delineate if the child has autism, which means they just have those characteristics that qualify under autism. And then do they have something else? Because not everybody with autism, like people with Asperger's, don't have the intellectual disability. And that was the big delineator there.
Okay, so I'm going to ask, and I'm going to throw this out. I know that this is a controversial statement I'm going to make, so I'm just going to say it, that preface that. We used to use the words mental retardation, and I remember when I was in graduate school, I worked at the Hudspeth Mental Retardation Institute. We don't say that anymore, but what's the correct terminology, and where do we kind of identify what's autism versus what the new term is now, and how do we make some differences, and is there testing that's involved? And if you could help with kind of that delineation would be wonderful as well too.
Great questions. And actually that's a great point, because the rates now are 1 in 54. Why is it so high? Well, we've gotten a lot better at testing, but that's not there truly is an increase in autism spectrum disorder. But we have gotten pretty good at testing. Typically you would have a neuropsychological assessment. Usually that's when they're a little bit older. Some people are doing it. You can do it as young as 18 months. And that's a full battery of cognitive tests. You could also get diagnosed through a developmental test, which is done with a developmental pediatrician, an occupational therapist, speech therapist, and developmental therapist. We have quite a few clinics in the Illinois area that do that. That's another way to get diagnosed. And they look at the milestones and where the child is. There are a number of screeners. The characteristics everybody uses are the DSM-5 ones. So it's looking at those repetitive behaviors, looking at eye contact. Is the child speaking? Is there an intellectual impairment? So mental retardation, which is now intellectual impairment, is a separate disorder.
Intellectual impairment. So that's what, just for everyone out there, that's the appropriate terminology these days. And then do we still look at levels? I mean, there used to be what we would say levels of mental
Yes.
retardation back in the old diagnostics. So now are we still looking at levels of intellectual impairment?
Yes.
Okay.
It's still severe, mild, moderate. That has not changed. So diagnosing intellectual impairment is still the same.
Okay, that's wonderful. So thank you for that, because I've loved the movement now where we say don't say the R word, and I'm a big fan of let's eliminate that, just like we've removed other words that are just pejorative. So I'm really happy to hear you say that idea of this is intellectual impairment. Okay.
Yes.
And now, when we worked together back at Alexian Brothers, now Amita, we did a lot of trying to figure out where was the line between obsessive compulsive disorder and autism. So, and you were wonderfully helpful with us when we were looking at this, and we had someone where we had some questions about. So I'd love to hear your take on how did you kind of come up with, where do you identify the differences between the two? What would you say?
And the short version, especially when we were training new therapists, was the best way to describe it is someone who has obsessive compulsive disorder wants to remove that behavior. That behavior, they're insightful that behavior is causing a dysfunction in their life.
Okay.
If it is someone with autism spectrum disorder and they have a stimming behavior, so a repetitive behavior that might not necessarily be OCD. Someone with autism can have OCD as well.
Of course.
But the differentiator there would be whether the person likes that behavior or not, or is that behavior serving a different purpose in someone that has autism. So typically it's an enjoyable behavior for somebody with autism who does not have OCD, and it's just a repetitive behavior. So that's where I start with differentiating between the two.
Could we talk a little bit more about self-stimulating behaviors then? Because that does seem to be something that's pretty common among people who are either on the autism spectrum or who have some of these more developmental kinds of, or intellectual disabilities as well. So what role do these self-stimulating behaviors play in helping people to regulate their emotional or environmental experiences?
The short answer to that is it helps them regulate themselves in a world that has sensory overload for them.
Okay.
So that's a characteristic that has to be present to be diagnosed with autism, and it would be restricted repetitive behaviors, interests, or activities. So those repetitive movements, if you see anybody flapping their hands, or I've worked with a lot of individuals who will move an object at a particular angle so they could see it from the corner of their eye. Those behaviors, self-stimming behaviors, serve a function. And a lot of times it can regulate the individual, but sometimes it causes them to go the opposite way and could also overstimulate them. But it's not something you can have the person just stop doing. It's not healthy to have them stop it.
So grabbing their hands and telling them stop is not going to help them. Just like telling someone with OCD to stop checking something isn't going to really help them. So, okay. All right. And what does it look like then for somebody who has both autism and obsessive compulsive disorder? I mean,
and I have seen that, and it does exist. It is really difficult for the person with autism because not only do they have the obsessive compulsive piece that is really causing havoc in their life and really hindering them from functioning, but they also have all of the characteristics of autism, so they don't necessarily have the insight to help themselves all the time, or they need, where a typical person with OCD might be able to get one treatment course and be helped, a person with autism may need to repeat that process, may even need a higher level of care. and have that repetition of how to help them with that OCD piece.
I'm going to admit to a little bit of a workup that I did to this week. There's a Netflix show about dating on the spectrum, filmed in Australia, and I've been watching a couple of episodes of it recently, and it is a fascinating look at watching people who have autism, and very often Australia seems to use a lot of Aspie and Asperger. They say Asperger's because they don't pronounce the G the same way we do Asperger's. But watching the interactions between two people who are on the spectrum and how at times, if there's one thing comes up that they don't like about it's done. Like it's just kind of like, they interviewed one person who really loves dinosaurs, and they said, what if you met someone who did not like dinosaurs? He said, it's over. No, there's no way.
They mean that.
They mean it. Yeah. Like, done. I can't, it does not compute kind of thing. So, I don't know if you've seen it or not, but I highly recommend it because it's a fascinating look into something that I don't think most people think about, that people on the autism spectrum still want love and respect, and to live a life like they see people who aren't on the spectrum doing. And yet it is 10 times more complicated for them to go on a date. I mean, they were showing a lot of these individuals, and here's what I liked about the show. They were showing a lot of these individuals who were going to dating workshops and practicing, but then when they were doing speed dating, and I think if you got a whole bunch of people in speed dating, they would just kind of go down, hey, who are you? What do you know? And for the people on the spectrum, there were cards at the table. If you get stuck, pick up a card and ask a question, right? And yet, so it was just kind of interesting that I wanted to ask you this. The world to us seems like a pretty normal pace. I'm going to bet the world to somebody on the spectrum is like supersonic, and it's just, things have to slow down so much potentially because they talk about feeling overstimulated so easily. And is there something, here's my long round way of getting to this question, is there something in their brains that can take so much and then it's like, it's too much, and like the processing level is just potentially different. And I don't mean that in an oversimplified or stereotypical kind of way, but I want to understand that and kind of what you think. So.
Yeah, I think you bring up two really good points. One, I did want to touch on that empathy piece. I think in the media, they have shown people with autism spectrum disorder of any type to be these unfeeling individuals. That is so untrue. They want to be loved. They want to be in our social world. But it's almost like one described it as an alien entering our world and trying to figure out the social nuances and the cues that we learn by observing their environment. They don't learn that. And like you said, what happens in their brain? And that's why I'm a big proponent of, at some point, a neuropsych needs to be done. Why?
Okay.
Because the neuropsych will help the individual know which part of their brain that does become overstimulated.
Sure.
Is it that their processing speed is slower? Because that's not the case for all of them. Is it that their threshold is much shorter than others? Are they really concrete thinkers, or are they able to look outside of that? So I think that's a huge piece of, knowing that. And unfortunately, when they're younger, parents kind of have to figure out what that threshold is. Like, for example, a kid who likes to jump to self-regulate themselves, and the parents buy the trampoline that they put indoors, and the child will jump on that trampoline and they're like, great, okay, they're occupied, they seem calm. But if they let them jump on that trampoline 1 minute too long, from that individual's inner thresholds, which we don't know what it is, right? They can't tell us. then we've flipped that person just to overlook,
Wow.
and then
Wow.
we have problems.
So maybe someone with OCD can tell me how overwhelmed they are, but I'm wondering someone on the autism spectrum might not have the ability to express that to me. Either maybe in subtle behavior, but not in words or something like that I'm used to. And so it's probably so much more important for any therapist to get some training in this, to be able to read much more subtle types of cues than we would normally. I'm used to subtle cues working with OCD of subtle safety behaviors. If somebody moves their hand slightly or puts something, like you said, in a certain angle, or how they sit down, or panickers, if they walk in with a big water bottle. I can easily diagnose panic disorder by the size of a water bottle someone has. Just there are little things that are tells for certain anxiety disorders, but I'm assuming there's got to be certain types of tells that you start to learn for people who are on the autism spectrum as well too.
Yes, and I'm just thinking of the young adults. You and I actually have worked with a number of young adults where it starts as just extreme anxiety, right? And the parents can't, sometimes if the parents are still involved, the parents are distraught because this child is brilliant. And then they go off to school, and that's when everything falls apart, is when they go to college. And a lot of that is, we weren't picking up on that anxiety first. I think that anxiety piece is huge because they don't understand that they're doing these excessive behaviors because they are anxious, and not being able to tell their family that. So it's a lot of the therapist really looking at, is this behavior a repetitive behavior that's serving a purpose? What is the purpose of the behavior? And if the purpose is to somehow control the anxiety, then we really need to look at OCD, because the purpose of a self-stimming behavior is more, I don't want to say it's not anxiety at all, but it has more of a stabilizing physical purpose than it would for someone who was who used that OCD piece of walking in the room 3 times before they would actually enter the room fully.
Wow. Okay. Once again, everyone, this is the No CD webinar. We do these every Wednesday night, and every third Wednesday of the month, we do a Diversity Matters series. That is tonight, and tonight's topic is autism and OCD. My good friend Maria is here with us tonight, who we know we love each other because we choose each other relentlessly, and that is why we know that we love each other dearly. Were we serious with each other, we probably would not like each other whatsoever. But we are very good at giving it to each other as much as we possibly can in the most sarcastic way that we could possibly find. So. And for those of you who are looking for teletherapy, No CD provides teletherapy. We continue to work with more and more insurance companies throughout the country. And I'm excited that one of the things, we're always looking at further training for our No CD therapists too. So they're very well trained in OCD. They're very well trained in exposure and response prevention. Later in the next week or so, or week or two, Maria and I are going to record a training on OCD and ASD for our No CD therapists as well, so that they all become educated even more in those areas as well too. So we continue to make sure that our therapists have the highest level of education available. So once again, Maria, thank you for being here. Now, tell us a little bit about the private practice that you're starting up, and then I'm also going to get some questions pulled from our chat as you tell us a little bit about what you're going to be doing and how you might be able to help some people out there who have questions about these things.
Great. So I see individuals with developmental delays across the lifespan. So if they have autism spectrum disorder, I will see them across the lifespan. Otherwise, I see adolescents and children mostly. I specialize in the difficult cases that most
I would say so. Yeah, I would say
don't want. And I really love what I do. I think I've had some life experience with it as well. I've had a lot of training. I do a full day in Oak Brook, Illinois, and then the other days in Arlington Heights. There's a number of different curriculum that I use and therapy modalities based on what the person needs. Depending on the functioning level of the individual, we might do some exposure therapy, or sometimes I like to work with the team. So if there is some comorbidity going on, I might bring in an OCD specialist, and maybe I'll work on the autism piece, and then somebody else will work on that OCD piece. I do take a family approach. When someone has an individual in their house with autism spectrum disorder, the whole family's impacted. And there's no way we can help just that one individual without bringing the people who live with that individual on board. So my practice, like I said, is called MGB Services for Motivate, Grow, and Become, because we think everyone has the potential if they want to change or if they want to learn different behaviors.
So I'm going to throw some chat questions that have come out, and then I'll go back to some of my own too. But I want to give people out there some chances to throw some things in. I have a teen diagnosed on the spectrum, high functioning, and can sit and draw for several hours every day, and in between be on their computer and cell phone. We've wondered if OCD is involved. What might be some things that would say to a person, specifically in a case like, I mean, we talked more in general, but that OCD would be involved? I mean, I would say that it would be that I have to do this in order to potentially prevent something bad from happening. But I could see that being on autism as well too, that there may be some associations that get easily made by something. You know, I remember reading The Curious Incident of the Dog in the yard, and he didn't like seeing yellow cars, because if he saw a yellow car, that meant that it was going to be a bad day, right? So how I know how difficult it is, and you and I spent sometimes hours discussing some of these cases, but how difficult is it to kind of then ferret out what is going to be an OCD versus an ASD type of experience? Or in the end, does it always need to matter as much as long as we can do some good therapy? What would you say?
I would say a little bit of both. I think you need, a therapist needs time with the individual. They're not going to be able to figure it out from 10 minutes of just screening them.
Yeah.
I like to do a full interview, really trying to see what is the function of that behavior. I believe that every behavior has a purpose. So if that function, we go back to, is the function regulating or is the function impeding? So if it's helping them to regulate their day, even though it might be inappropriate, like flapping their fingers or twirling something, then we just we mold that and teach them what's appropriate and when they can do it. If it is obsessive, it really impacts them in a way where they're frustrated about it too. No one with autism spectrum disorder is going to be frustrated about their stimming behavior. They enjoy that behavior.
There we go. So that's it, versus there is frustration in OCD. I've stood next to somebody washing their hands crying because they don't want to be washing their hands, but versus someone with ASD is going to enjoy their stimming behavior. And
exactly.
It's a great way to put it.
I would say is the best way to look at it.
Mm-hmm. Now, this was interesting. What's your opinion on how autism presents in women? And this came up in that show I was watching too. Like someone had mentioned, autism seems to have been really developed around males. And I don't know if that's really the case or not, but it came up in the show, and now I get this question about autism in women. So do you find that there are gender differences in autism and how they present, or is there a bias in criteria in diagnosing based on males versus females? What are your thoughts on that? So.
Well, data shows there are definitely more males with autism spectrum disorder than there are females.
Okay.
So that's a fact. There truly are. From my experience, when working with women who are higher functioning, it is more difficult to diagnose because the old perception of women is it's okay if they daydream. It's okay if they're not social, because that means that they're just a quiet, proper young lady, or maybe just an anxious girl, or she daydreams. It is much more difficult if it is a higher functioning female to diagnose autism. I think if they have the visible characteristics, then that's much easier to see. I've seen data that when there are more of the repetitive behaviors, that it is more severe in girls a lot of times.
Okay. This is interesting. I have OCD. My brother has autism, and I think sometimes we trigger each other. Anything that we could do for that when this happens? Well,
Sibling.
I can see that. Now, imagine somebody with OCD keeps straightening something but makes a lot of noise while doing it, and somebody with ASD who is very triggered by a certain sound or something like that, then going into self-stimming behavior, which could then cause other things to get moved or something. And boy, you could just see that it's a perpetual motion machine here going after a while, right?
Yes. Gosh, I could use a personal example on this one. So I have 3 children, and my oldest is the one with autism. And one of his behaviors is that every morning he wants everyone in the house to say good morning to him. And he will not stop until every single member of the house says good morning. So I have one of his siblings who is more obsessive and wants meaning behind the greeting, refuses to say good morning, because he knows that is feeding his need to just hear the word. So they trigger each other. So he won't reply. And so my other son will not reply to the good morning, which causes my son with autism to just keep saying good morning. So they do trigger each other.
Wow.
It's very interesting sometimes.
Who wins that one? Or is it, how does
wins? That? Yeah. Sometimes nobody.
Sometimes nobody.
And that's one thing I've learned from living with somebody who has autism is the biggest gift you could give that person is to teach them how to be flexible. Because it's very easy to get stuck in their patterns of life because it makes your life easier.
Yeah, the biggest gift I think we give people with OCD is learning how to live with doubt and discomfort, and recognizing that everybody lives with those things and that it's okay. But OCD, of course, says that's not acceptable. And at least in this instance of life, there should be no doubt and there should be no discomfort whatsoever. There has to be 100% assurance that everything's going to be fine without any discomfort whatsoever. So that's interesting too. There are some similar goals that I would say in working with the two populations about being okay with not always getting what you want, or being okay with OCD not always getting what it wants as well too. Yeah. Okay. Let's see. My brother has autism spectrum disorder. Oh, good. My brother has autism spectrum disorder. And when he gets upset, angry, or frustrated about something, he can get really aggressive and lash out, and it triggers my OCD. So there's another one where could the difficulty in expressive language come out in other ways then as aggression or things like that, because it's just too hard to use words to describe what's going on? Or what would you say for that?
That depends. It really depends on whether there's comorbidity. There are individuals with autism who can become aggressive, and there's a number of different reasons. It could be their lack of understanding of the situation. It could be the lack of the verbal ability, or it could be a comorbidity.
Yeah. Okay. I was diagnosed with autism in 1994 when I was 4. I was diagnosed with OCD when I was 7. I don't typically feel they play off each other unless it's a sensory related issue. It's amazing to see too how the diagnosis process has improved over time. So yeah.
Great. That's exactly, yes. That's another way to really look at the difference between OCD and autism is that sensory piece. It is different.
Okay. My child has an IEP and is being tested for autism. It will be done through the school. What is the exact verbiage to use so my child's IEP spells it out correctly? So for those of you who don't know, an IEP or an individual educational plan is something they use at schools, or they also use a 504 plan, which doesn't have as many legal ramifications as an IEP does. But this is interesting, Maria. I'm sure that this is a big piece of schools and everything for inclusion and that type of stuff. So what are we seeing in terms of autism schools and that type of thing?
Most schools go by the DSM-5, and they will literally go through each characteristic at the person's IEP. The question would be, when they're doing testing, is asking what are they using? A school typically doesn't diagnose. The medical diagnosis of the autism is what I mean. So they could have an educational diagnosis of autism spectrum disorder. And I've seen kids who have that, but then don't have the medical diagnosis.
What's the difference? How would I get educationally diagnosed with autism and not medically diagnosed with autism?
Typically that happens when the school is the one that does the assessment. And the only place that those behaviors are being seen is in the school. The family might be saying, well, we don't see that at home. So that's educational autism. There's also the flip, where children could have a diagnosis of autism spectrum disorder from a medical doctor, but it won't be accepted in a school because it's not impacting their educational functioning. And that's where you really need to hammer things down more, because that social piece, that social emotional piece, is one that sometimes is overlooked, but that's huge, because as they get older and the demands, the social demands increase, then they start having more issues.
Yeah. I won't say who this is, but I know someone who said, you know, if it was just me and my son on a desert island, he would never know he had a problem. And it was interesting because they went for a long time without getting the diagnosis. Unfortunately, long enough that he never developed verbal skills because they waited because I think it's about age 6 or 7 that window starts to close about developing verbal, right? Is that correct? Or
I think every kid has potential.
Okay.
Even they say that is the time, but I've seen kids who have spoken later. And
really? Okay, great.
Yeah. And I could tell you my son didn't start talking till he was 9.
Oh, all right. Well,
so
wonderful. Good. I'm glad that, you know, that's what I had learned in grad school, but, you know,
right. And that is
a
still
long time ago.
But that is still where the physicians do go by that. That
They
is
do,
by
right.
5 or 6, they probably won't develop language. But our personal experience has been that I've seen that difference.
Okay. And boy, here's the other piece. And I'd love your opinion on this as a therapist. There are times I go to someone's home and I meet their child. And because I've worked with you and I know things, within a few minutes, I'm thinking, this child is on the spectrum, right? And yet no one else sees it. And I've been in some really uncomfortable scenarios where I want to just say something to them and be like, I start doing some treatment now, because we could really help some of these things that are going on. And I did once say it to a good friend of mine. And I said, listen, this is going to be a really hard conversation right now. And I'm putting on my professional hat. And I want to remove this from our friend hat. But I really think that it would benefit you to go get your child evaluated for something. And they were a bit disappointed, but when they finally did, and it turned out that, yes, they came back very thankful, that said, you know, we needed that push. We didn't want that to be, we didn't want to see it. We knew it was something was different, but we just didn't want to kind of go there. So I don't know how you feel about that too, but it's just interesting now being in the field and knowing something about it, that it's easy to spot in other places.
I do think a trained eye can see it.
Yeah.
But it still needs to be diagnosed. It still needs that
absolutely,
full battery, but yet, yes.
I do the same with OCD. If I'm at a restaurant, I'm watching everybody else. I'm okay. That person picked up the salt shaker with a napkin after spending about 5 minutes putting their knife in the right spot. You know, I just think there might be some OCD going on over there. But I don't go up to them and say, by the way, sir, I just wanted to give you my card and say something like that.
But you might say it under your breath, right?
Yeah. But then when people do come and ask, I mean, I will give a very honest opinion on something if they ask for it. But,
yeah, if someone asks me, I will give them my honest opinion. If they don't ask, usually there's other things going on. And I've been in that situation where there's friends, and usually there's always something else. So I will just encourage, just go get tested. You have nothing to lose.
You have nothing to lose, yeah.
Right.
And you have so much to gain because there are so many, now more than ever, there are so many amazing programs out there to help families and individuals to be able to grow to your best potential.
And there's so many free screenings.
Yeah.
I can tell you I had all of my kids screened because I was just a little paranoid there.
Sure.
But it's free. It is free. And there are studies that show siblings of individuals on the spectrum tend to have some little characteristic that might not be. I'm not surprised to hear that we have siblings with one who has autism and one who has OCD, right?
Yeah.
Because some of those characteristics can be OCD characteristics. You could also see it where one kid just has the sensory piece. And then one kid might just be more of a concrete thinker, not necessarily to that point of diagnosis, because diagnosis is when it impedes your daily functioning, right? So you're not going to get a diagnosis until that happens.
Yeah. Let's see. I stim when I'm overwhelmed to calm myself down, or when I'm happy even. It just makes life easier. So that kind of feeling that if you find something that feels good, you may do it, right? And because you learn to apply that to many areas of your life. All right, here we have one. I have Asperger's and OCD. I've always had slight symptoms of OCD, but this year I had a sudden onset of severe OCD symptoms after a recurring infection. I'm an adult, but I was wondering if it could be due to an adult form of PANDAS, or if that's even possible. So PANDAS, pediatric autoimmune neuropsychological disorder associated with streptococcal infection, or now PANS, pediatric autoimmune neuropsychological syndrome. I mean, obviously we see this more in children, but I'm not going to be surprised we'll see these things in adults as we just learn more as well too. Nor would I be surprised that somebody could have had PANS earlier and now a significant enough infection later on in life would be something that would kind of trigger that cross of the blood-brain barrier with the antibodies to the strep or whatever infection it is, attacking the basal ganglia or other areas of the brain, overwhelming it and making OCD symptoms develop, or tic or Tourette symptoms develop overnight sometimes, or get worse in people who already have them as well too. So has there been any link with autism and something like that, with maybe illnesses or things of that nature?
There is some research on some of that. There is one strain of autism that can be identified genetically. In my career, especially when working at Alexian there, only twice did the doctor give a diagnosis of PANDAS. So not all physicians believe in that either. And that's the difficult part, but I know that we definitely seem to, and after following up with those two families, it definitely was a different manifestation than what you would normally see.
And we sure saw it in the OCD program. We saw PANDAS. I mean, yeah, for sure. Andy says, I exist. So, Andy, yes, you do. And my niece is on the spectrum and seems to have repetitive thoughts, which she knows are repetitive and hates them. How does this happen?
Ooh. So she's on the spectrum and she's having repetitive thoughts. But she doesn't like them.
Could be a little bit of both OCD and autism spectrum going on here, correct? Now, I would look at, are the thoughts met with compulsions to neutralize them? If so, then I would have a more definitive diagnosis of OCD on that. If not, we'd have some other things to try to take a look at and investigate. So, Sal, I would say one thing that you would want to do in that situation is find a provider who can really help to kind of delineate what's going on with this, if that's the case. Yeah.
Yes. Sometimes thoughts could mean a lot of different things. And if you're on the spectrum, that could be misreading some situations.
Mm-hmm. Okay. Let's see. Oh, someone else watched the dating show for people on the spectrum and said it just gave her a much better understanding about how people on the spectrum view the world and look at things. Yeah. Here's another one. I have autism and OCD. I understand OCD pretty solidly. My difficulty comes down to older therapists I've had who don't take my distress seriously, as I didn't emote as a neurotypical person. So I'm assumed to be exaggerating or faking. Is this common? That's a great question.
That is a great question. I wouldn't know unless I met the person. But I think sometimes people with autism really do get misunderstood. If somebody is not used to working or has training working with somebody with autism, it's very hard to understand the concrete thinking, and that sometimes emotions are probably displayed more so than a typical person. I can see that happening.
Mm-hmm. Wow. Once again, a reminder, everybody, this is the No CD webinar. We do this every Wednesday night from 7 to 8 Central Time. The only time zone that, right? The real,
only one. Yeah,
the real
one. Yep. We're the only real ones.
And for those of you who need treatment for OCD, you can download our app. You can utilize our community. You can get a free 15-minute call with our care team. You can go to treatmyocd.com also if you want to book that call. And you could do it also from the app, which you can download from iOS or Google Play. And on the third Wednesday of the month, we do our Diversity Matters series. And tonight's Diversity Matters series is with my very good friend Maria. Hello. And we are talking about the interaction of OCD and autism. And if you go to the very beginning of the chat function here, you will see information about how to contact Maria. If you would like, if you have some specific questions and you're in the Illinois area and you'd like to maybe even see her about what autism and maybe some links with OCD as well too. So, because Maria and I will always consult on cases if she ever gets one. So, because we like each other. So, oh yeah, I like that. I have friends who say the R word and they claim to mean it's calling someone dumb. I'm offended they would ever say that. I'm offended too. I'm
offended. I hate that word.
Yeah. Mm-hmm. Yeah, let's get rid of that one. My 14-year-old son has OCD and ASD. How rare is it for someone to have both?
I think at one point it was said that you couldn't have both. And I think there was discussion about that. It's possible. We know it's possible. We've seen it.
Oh, of course. Yeah, we've treated it together.
Yes.
Yeah.
And let me see. I might even have data on that.
Dun, 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 dun.
Yes. Let's see if I do. So it is, as a comorbidity with autism spectrum disorder, it's 37%.
Wow.
Yep. So it is definitely there. It exists. 30% would be ADHD. Depression is 10%. And then specific phobias are 44%.
Mm-hmm. Mm-hmm. That makes sense. Yeah, absolutely. Eric says, I really appreciate Maria's explanation. She gives me hope to know there's help with OCD. I have intense OCD and anxiety disorder. She sounds very knowledgeable. Yes, well, she is very knowledgeable. So thank you. Here's a good question. Adam, I suffer with undiagnosed OCD and ADD, but I'm wondering if there could be a relationship to autism spectrum disorder in this case as well. I mean, as you just said, the comorbidities are potentially there. So Adam, your best bet is to go and meet a professional who can do some assessment with you. Yes. So that you can really kind of figure out what's going on and then get started on the best kind of treatment regimen, whatever that may be. So, and
I think as an adult, can I just throw something in there real quick? It is harder to diagnose in adults with autism. So you really want to go to someone who knows autism, who has diagnosed it before. But a lot of times, if we don't have that early data from when they were younger, could be categorized as something else. So you really want that data from when you were younger.
Yeah. Here's an interesting question. Are there racial disparities then in the diagnosis of autism too? And we did our very first Diversity Matters was on Black Lives Matter and taking a look at OCD in the Black African American community and how there are underdiagnoses, people suffer more. What are the cultural implications of that and stuff too? How do you see that in the autism community?
I would say it's parallel. They're not getting diagnosed. Really? It's a systemic issue. I agree. That was one of my roles when I was at AMITA, to really find those at risk. And yes, there is definitely a disproportion. Even getting that information out for early intervention. Early intervention is free in almost every state. So getting people there and getting that word out, but there is still disparity.
Yeah. Yeah, I'll say this, that the reason that NoCD does these Diversity Matters webinars is after what happened with George Floyd, and I just decided that too many times we have a national tragedy and everybody's up in arms about it, and then a month later everybody forgets about it. And we see that with gun violence and various things and stuff, and I just said, we're done with that. So we made it official that we were going to do a Diversity Matters series once a month. And that's just now a part of the culture of what we do at NoCD, is to make sure that we talk about these types of situations. And we may not solve them right off the bat, but we are going to bring them to light and up to the attention. And if we can bring in experts and people who know these things, or if we can be involved in the future in studies and data collection or something, that's a passion of mine, to make sure that NoCD is at the forefront of taking a look at how do we bring mental health awareness and treatment to other communities than the Western cultural community. So, because I think that that's so very, very important. Let's see. Is stimming only a symptom with autism? I'm not diagnosed with autism, but often do stimming behaviors not related to my OCD obsessions?
You could have sensory integration disorder and not have autism.
Right.
So,
well, and I'll just bring this up. There's lots of behaviors that people do that aren't OCD, like nail biting is a self, while on one hand it might be nail, but there could be a lot of self-stimulating experience that goes on with nail biting, right? Or trichotillomania with the hair pulling. Some people play with the hair and they really enjoy it. And then when they pull it out, they rub it between their fingers, and some people put it in their mouth. Some people even chew it or eat it or something like that. There's lots of different types of stimming behaviors, not just the flapping that we kind of characteristically think of that's the one probably people talk about the most in autism spectrum or something like that. But there's lots of behaviors that we'll do bodily that may be soothing to us that other people may look upon and go, why is that person doing that, or something like that. So,
right. Not everything means you have a disorder.
Correct.
Not every behavior.
And then there's even differentiating between, someone said, what is stimming? So self-stimulating types of behaviors, things that you do to maybe let out energy or something of that nature, something that you do to make you feel good, that other people would look at and probably not really understand, why is this person doing something like that? And I had something and I totally forgot it, because now I went to that. So hopefully it'll come back to me.
Well, like chewing a pencil.
Yeah.
A lot of people chew on the pencils or chewing on straws.
Mm-hmm. We should do this one again. Okay, well, we could think about that. Since I have OCD and my brother has ASD, I'm interested in learning more about how we can manage both of our disorders so my brother and I don't trigger each other. That's coming up a lot, that triggering. But I think that it points out here, just look at the people who are on our webinar who are talking about having a sibling who has one or the other. Mm-hmm. So how right there, that's pretty fascinating that we see that. Let me pull up a few more here. And for those of you who are bringing up some non-autism questions, please come back next week and throw those questions out. We'll go back to our usual webinars next week as well. I have OCD and my brother has autism. Do you think my children will be more likely to have OCD and autism? And do these disorders typically spring up together in families?
Short answer, yes. Your risk definitely goes up if you have a sibling or a child with autism. Your chances of having another child with autism definitely increases.
Same with OCD, that if there's one first degree relative with OCD, the chances of another first degree relative goes up. That's true. But I also want to say it's not the cause, right? You know, so I would never look at a parent who has OCD, who has a child with OCD, and say, well, it's because you have OCD. No,
exactly. That's huge. Yes,
Mm-hmm.
that is very true. Because at one point in autism, it was the mother's fault. Historically, the refrigerator mothers.
Let's face it. At one point, it was always the mother's fault.
It's always
for
the
everything.
mother's fault.
It was
always, yes.
The toileting or whatever, just
everything's mom's fault.
I have a parent on the autism spectrum as well. Both of my parents struggle to understand my OCD, and particularly my parent with ASD. She gets easily overwhelmed by my OCD outbursts. How can I help my parent who wants to help me help me?
Get into therapy together.
Yeah, I would agree that this is a ripe experience for an expert to come in and help mediate a conversation between the two of you, right? Mm-hmm. One thing that I've always said is when I'm doing really good therapy, everyone's, and it's like couples or family or something, everyone's going to leave the room unsatisfied. And what I mean by that is nobody won. Right? No, I didn't pick one and say, you're the winner and everyone else is wrong. We all had to come to a compromise, and nobody got exactly what they wanted, but everybody at least got something of what they wanted, right? So there is some disappointment in there that I didn't get everything, but hopefully there's some gratitude that I got something. So I want to leave with this because I think that this is a good topic before we wrap up. And I've seen this in the OCD community. So I want to talk about the autism community, and that is parental guilt. I hear all the time about what could I have done to prevent my child from having OCD, and or parents who unwittingly provide safety-seeking behaviors to their children, who buy them more soap, or who do say good morning to them every morning in the way that they're supposed to, and all those things. But then over time, notice that it goes from good morning, I love you, good morning, I love you, please give me a kiss on the left cheek, good morning, I love you, please give me a kiss on the left cheek, then the right, and every day there's a new thing added to it. And now it's an hour to say good morning to somebody like that. So, so I have to pull families away from this who then just feel, on one hand, horrible that their child is now suffering because they're not doing this, but also horrible that they played a role in this all happening. So let's talk just for a moment before we're done about parental guilt in the autism. Mm-hmm. And I know this is touching for you, having a child on the spectrum. Yeah.
And my newsletters actually at the beginning of the pandemic actually touched on this. No one is perfect, right? You're going to have a bad parent day. And I always say there's tomorrow. It's not your fault, right? And you pick your battles. You have a plan. You stick with that plan. But even if that plan doesn't work at the end of the day, you don't beat yourself up about it. You just say, okay, it didn't work today. We're going to try it again tomorrow. I think that parent guilt piece is very big. The biggest gift you could give your child, like I said earlier, is that flexibility piece. It's hard work on the parents. It's hard work on the whole family, but there's always tomorrow. And especially during the time we're in now, it's really hard not to get stuck in ruts. So having a plan, I think, is huge. And then giving yourself a break. Parents of kids with autism or a family with autism spectrum, you need a break from that individual. That individual needs a break from you. And that self-care piece is very, very important for everyone in the family. Sometimes the siblings are overlooked and they need that care as well.
Mm-hmm. Yeah. I know some families that when their child goes to camp for autism, that's focused on that. The rest of the family goes on a vacation somewhere else, and they all, because it's a break for everybody, and that's okay.
And it's okay. And
Mm-hmm.
that is a great motto to have, is that's okay. My child's an adult now, and I had a really hard time when he was younger, not bringing him everywhere with us. And, one of our therapists at one point said, but he would have a lousy time. And I thought about that.
Yeah.
And I'm like, you're right. He would have a lousy time.
Mm-hmm.
So really it is you getting over that too. I mean, there were times where I knew we'd go on vacation and I'd be working that whole time because my child would need so much attention. But then there were vacations where I knew he would just be miserable. It's okay not to take them. Yeah. I'm not saying don't take them ever anywhere.
Sure, of course, yeah.
But it's okay to give yourself a break.
Pick your battles, right?
Pick your yes. Good morning is not a battle I pick. Yes, pick your battles.
Yeah. Once again, give us all your info so that we have, and we have it at the beginning of the chat. But here's your shameless self-promotion time, please.
Okay, great. So my name is Maria Bellantuono. I am with MGB Services, stands for Motivate, Grow, and Become. Our number to reach me is 847-701-4409, or you can email me at mariab@gmx.us. Thanks, Patrick.
Maria Bellantuono, one of my favorite people in the whole world. Thank you so much.
Thank you, Patrick.
I miss us getting to work together. I really do. But
we're not this nice to each other when we're together, by the way.
No, normally we're slamming each other constantly.
Yes.
So we've really done well on this one. This is the nicest we've ever been to each other, actually, I think, in this last hour.
For a full hour, yeah.
I'm impressed. But I really appreciate your openness about yourself, your family, what's going on and everything, and that you've taken that work into a specialty and you've brought it out to a community so that people can learn from you, not only academically, but personally as well. And I think that's wonderful. So thank you for what you do.
Thanks for having me.
All right, everybody, have a great evening. Remember, download the NoCD app at iOS or Google Play, and we will be back next week to do another round of our Wednesday night webinars. Talk to you then. Bye.